Welcome to today's episode. We have this massive stack of clinical guidelines and, patient case studies regarding GLP-1 medications like Ozempic, Wegovy, and Zepbound. And our mission today is really to answer the one question everyone researching these eventually asks. Would a doctor actually prescribe this to me?
Yeah, that is such a loaded question, right? I mean, for anyone who has hit a weight loss plateau, there's just so much emotional weight tied up in that. You have the frustration of temporary weight loss, the gradual regain, and then just that inevitable self-blame that follows.
The self-blame is exactly what today's source material dismantles, actually. The medical research we're looking at shows that regaining weight isn't a discipline failure. It's an evolutionary survival mechanism where your body actively fights to keep your weight stable.
Wait, explain that part again. Why would the body fight against something that is ostensibly making it healthier?
I know, it sounds counterintuitive, but it really comes down to metabolic set points. If you start losing weight, your biology basically
Oh,
panics.
so that thinks you're starving.
Exactly. It thinks you're starving, so it cranks up hunger hormones and slows down your metabolism to preserve energy. It acts like this stubborn internal thermostat.
That makes so much sense, and it really shifts the focus away from just, trying harder to actually addressing that biological panic.
Yeah.
So how do GLP-1s or glucagon-like peptide ones actually intervene there?
Well, it completely reorients the goal. They essentially impersonate your body's natural fullness hormones. But instead of disappearing from your bloodstream after 10 minutes, these medications hang around in your system for a week.
Wow, a whole week.
Yeah, a full week. So they are constantly signaling to your brain that you are full.
But wait, if they just signal fullness by slowing down how fast your stomach empties, why doesn't eating a massive, heavy meal do the exact same thing?
That is a great question. It's because slowing gastric emptying is really only one part of the gut-brain axis.
Hmm.
The medication also directly targets the receptors in your brain to reduce food noise.
Right, that constant mental chatter about food.
Exactly. And simultaneously, it increases insulin to clear sugar from your blood. So it's working on multiple levels.
So stepping back for a second, what this really means is the drug is rewiring that stubborn thermostat rather than just forcing you to physically eat less food.
You nailed it. And because doctors are realizing the scale doesn't tell the whole story, they've started looking at that underlying metabolic strain to determine who actually qualifies.
That might explain something I've been noticing online. There is this massive misconception that you only qualify for a prescription if you are at an extreme, life-threatening weight.
Yeah, the data absolutely contradicts that extreme weight myth. Clinical guidelines look for a body mass index of 30 or higher, sure, but they also approve a BMI of 27 or higher if you have what they call comorbidities.
Like hypertension or
Yeah.
type 2 diabetes, right?
Right, exactly. So it's not just about extreme weight.
So if I'm understanding correctly, a doctor is evaluating your blood glucose, cholesterol, and overall health history to see if this treatment aligns with your specific biological profile.
Yeah, that is precisely what's happening. And it reflects a massive shift in how medical organizations now officially treat obesity as a chronic, manageable disease.
Treating it as a chronic disease completely changes the approach, and it aligns with a surprising finding in the patient data, which is this shift away from solo dieting and toward comprehensive physician-guided GLP-1 programs.
Yeah, that ecosystem of support is critical because we really need to set realistic expectations for anyone considering this route. The research makes it very clear that this is not an instant fix.
Right. I mean, I imagine just taking a shot doesn't automatically override decades of metabolic issues overnight.
It definitely doesn't. And that is why the protocol requires titration, meaning you have to start with a tiny dose and slowly step it up over months so your body doesn't freak out.
Oh, okay. So you really have to ease into it.
Exactly. It requires continuous monitoring and a lot of patience, since your results will vary heavily based on your baseline metabolic health.
That is a really important reality check for listeners hoping for a quick fix. Synthesizing all of this, candidacy is really about identifying who benefits most biologically while minimizing their physical risk.
Exactly right. Interestingly, while researching this episode, medically supervised GLP-1 programs consistently appeared in patient case studies and clinical discussions as the safest way to navigate all of this.
Yeah, having that medical supervision combined with nutrition and coaching seems to be what actually works long term.
Definitely. And if you are curious to learn more about how those structured evaluations work, there's a link in the description you can check out.
It completely changes how you view metabolic health and personal responsibility. It leaves me wondering, if we start intervening early with these metabolic tools, how much long-term disease could we prevent entirely?